A very good afternoon to all of you. I'll be talking on the basics of a good uveitis workup. So, if you think of a good or a standard uveitis workup, there's nothing like that. Basically, the workup of for every patient has to be custom tailored, and it depends on every patient, depending upon the history of the patient, the demography of the patient, the clinical features, and the underlying risk factors. And of course, when you look at the eye, it's important to review the patient systemically because that's where you get some of the clues in some of the patients. So I've divided this talk into these three boxes. There are some cases where the clinical presentation is so classical that you really don't have to do any laboratory tests. You can make a diagnosis there. The second box is the same, where you have a classical clinical presentation, but you need some ancillary testing to confirm or to corroborate your diagnosis. And the third box, I will not be talking in detail because it is not at your level, at the postgraduate level, where the presentation is not classical, it's a mix-up, everything is confusing, and that's only for the experts. So let's talk about the first category where the presentation is very classical and the clinical clues are good enough. So for example, you have a case of viral anterior uveitis or Fuchs uveitis, toxoplasmic retinochoroiditis, acute retinal necrosis, and progressive outer retinal necrosis. So if you are asked in your exam, what are the clinical entities in uveitis where you can diagnose solely on clinical examination, these are some of them. Now you have a patient like this. You look at the so on the right you have pigmented keratic precipitates. There is little bit of corneal involvement. You have the patient presenting with you with some lesions on the nose, and if you still ask the history and examine the patient more thoroughly, you find these lesions on the back. So you have that, you know now the patient is a patient of herpes zoster. This was a case of viral anterior uveitis. Even if the patient does not have these lesions on the nose or on the back, sometimes they give a past history of zoster infection. So you have to clinically correlate, but if you look at the signs in the eye, they are pointing towards viral uveitis. Many times the patients may not present to you in the active stage like this. So this is where the patient has had an episode of viral uveitis in the past, so they are presenting to you with some patches of iris atrophy, which are more clearly seen on transillumination. So if you have these features, you know that the patient has had viral anterior uveitis. It depends upon you to look for any activity. If it is active, treat. If it is not active, just wait and watch. Now you have these stellate capes all over. They may be in the lower half or they may be upper half. Now what is important is the rest of the cornea is clear. There are no posterior synecdoche. There may be cells, but don't overtreat them. And if you make a nice slit, you see posterior subcapsular cataract. Sometimes the posterior subcapsular cataract may not be seen, or it may be very subtle where it is just beginning. But if you have these kind of stellate or fine capes, no posterior synecdoche, and then dilate the fundus, and you see this kind of hazy fundus or vitreous membranes, you're dealing with Fuchs uveitis. So many times you may also have seen that sometimes these patients are treated elsewhere with a chronic kind of uveitis and they are on topical steroids. Even some have received posterior subtenon Kenacort. So this is kind of over-diagnosing, over-treating. So this is a Fuchs uveitis and you have to be aware of this entity. You don't need any investigations here. I've already written the diagnosis, but if you have a patient presenting with floaters, sudden onset blurring of vision, you have this big retinitis patch. It may be in the posterior pole, it may be in the periphery, but it's like a headlight in the fog appearance. So this is a case of toxoplasmic retinochoroiditis. You may get a serology done, you may not get, but this is where the diagnosis is written. Any clues? I have the clue, you have to tell me the diagnosis. Louder? Louder? Before that? Acute retinal necrosis. So the presentation is so classical. It's the patient sometimes, brings the diagnosis to you. The most that you can do is you can ask any history of, chicken pox, and yes, the patient did give this history. So why I've written acute retinal necrosis with panel uveitis, because the patient did have some keratic precipitates also. Always make sure you get an HIV done, because old thoughts were that acute retinal necrosis occurs in immunocompetent patients, but it's not so anymore. Always any viral infections or any kind of this kind of retinal necrosis, get an HIV done. At least that rules out any underlying immune compromised status. So these patients, why I've written AC-TAP and FFA, I mean, you have made a diagnosis. Now it's up to the clinician to do more testing for admission, for starting antiviral therapy. So at your level, making a diagnosis is good enough. A child presenting with this, you have a quiet eye. They don't necessarily present with acute onset of symptoms. The eye is not red, but you see these posterior synechiae. Maybe there is cataract, maybe there is an early BSK. So these are the children with JIA. Always examine them systemically. And we had this boy, sometimes they have this bloated, the cheeks. So because they have been receiving steroids on and off, examine them, examine their fingers, their toes, ask for joint involvement, and examine the accompanying relatives. So in this case, it was the father who had these kind of deformities in the hands. So I'll come to the second kind of presentation. Again, the presentation is very classical, but you need some testing. So if you notice previous cases, I did not order any of the investigations. And please don't send these patients for Montux, CT chest, TPHA, ESR. They don't need it, unless it's the systemic examination asks for it. So you have this acute red eye. The slit shows there is a lot of cellular reaction, there is a lot of flare, and at the most you do is, first thing you order is an HLA-B27. Many of these patients have an underlying spondyloarthropathies, so you can order an X-ray SI joint. I'll come to that. But if you have fibrin like this, always try to dilate these patients. They are stubborn to dilate, but they would, and you will see a lot of posterior synechiae which tend to break. You have to do a complete posterior segment examination, because a hypopyon with a red eye not necessarily is always acute anterior uveitis. You have to rule out the other conditions, and I'll show you which ones. So try to dilate, start these patients on aggressive topical therapy, and rule out spondyloarthropathies by simply doing an X-ray SI joint, lateral NEP view. Now you have again a hypopyon. There is congestion, but the difference from the previous case is you don't see any posterior synechiae. Here you've dilated the patient and you can see the fundus, and I've shown you the angiography because we could see the fundus, we saw vitritis, and at our level we know that we are suspecting Behçet's disease. So here we did an FFA which showed the classical Fern pattern. So this was a case of a hypopyon uveitis because of Behçet's disease. Examine these patients or ask them for oral ulcers and ask them for any joint involvement or skin involvement. They need a rheumatology consultation. Now coming to another case of hypopyon. Now this is slightly different from case 1 but quite similar to case 2. So there are no posterior synechiae, but this eye was relatively quiet. There's not much of congestion. I said dilate, please do dilate, and here I'm not able to see the fundus. All that we are seeing is a yellow glow. So yellow glow, not able to see the fundus, get an ultrasound. So these are the patients of endophthalmitis. There is no trauma, so you are diagnosing a case of an endogenous endophthalmitis. Ask for a history of any IV transfusion, drug abuse, a dextrose infusion, fever, any uncontrolled diabetes. So underlying risk factors which may predispose a patient to an endogenous endophthalmitis. All right, so these are the different manifestations of a granulomatous uveitis. Now you know this is different from what I've shown you. The earlier were non-granulomatous. So here you have granulomatous. You can see granulomatous mutton fat KPs. You can see copy nodules. You can see Busaka nodules. You can see, posterior synechiae. So these are the patients who need testing now for, or a fundus showing a choroidal granuloma, vasculitis, serpiginous like choroiditis in different forms. So these are the patients who need at least a Montux testing, a CT chest. I would place stress on a contrast enhanced CT chest and not a chest X-ray, because chest X-ray has failed to give us any clues in our experience, and we feel that CT chest gives you much more information. These patients do not give you any history of systemic TB. They may be absolutely symptom free as far as the pulmonary symptoms are there, but CT chest is mandatory because it can give you subclinical lymph nodes in the body. TPHA, because syphilis can masquerade in it can mimic any kind of uveitis, and with this era, with uprising case, the syphilis being on rise, do not ignore, because if syphilis is positive, you tend to forget about TB, right? So these are the basic investigations for any granulomatous uveitis. You have to rule out TB, sarcoid, and syphilis. Granulomatous uveitis always does not mean TB, sarcoid, syphilis. At least pay attention to the eye, look for the other clues. Now, why I didn't order these tests in this case? Anybody? You would want to make a comment? Or did I make a mistake in not ordering these tests in this case? You have these large mutton fat KPs. So if you zoom out, there is a lot of lens material. So it's a lens-induced uveitis. So if you have this kind of clinical picture, please don't get carried away by TB, sarcoid. At least see what is there in the eye first. All right? You have these multiple pockets, bilateral, subretinal fluid. Your instant reaction is it's a VKH, but don't jump at diagnosis, because the moment you think of VKH, you would start high-dose steroids. But we have seen cases of chronic CSC or fibrinous CSC coming like this. The first thing that you would do, and must have seen your consultants do a fluorescein angiography just to confirm that you're dealing with VKH and not fibrinous CSR. And then you have the management of VKH. So you don't need any investigations. If you have bilateral exudative RD, don't go for Montux, CT chest, and all that. And if you see sunset glow fundus, again, you know that the patient has had VKH, so you're dealing with a case of chronic VKH. So, OCT is the first test I would like to do even before ordering an FFA, because the OCT would show a increased choroidal thickness with subretinal fluid. So the only tests that we need in these patients are for admission and for starting immunosuppression. So you are doing chest X-ray, CBC, LFT, RFT, but that's not for diagnosis, right? That's for monitoring and treating the patient. Similarly, sympathetic ophthalmia, you have the diagnosis. I mean, it's very clear. One eye, post-surgery, post-trauma, and the seeing eye develops cells or, KPs, or then you have the OCT showing subretinal fluid, choroidal thickness, and then just you confirm with FFA, which confirms that you're dealing with a case of sympathetic ophthalmia. The procedure remains the same as VKH. You have to admit the patient, start them on high-dose steroids and immunosuppression. Scleritis. Now, we are seeing increasing cases of infective causes. So whenever you see scleritis, make your chart as infective versus non-infective. Always test these patients unless there is an underlying autoimmune disease which is known. But otherwise, always test these patients for infective as well as non-infective. So in infective, you have a Montux, TPHA, CT chest. Non-infective, you are doing the rheumatological workup. ANA, ANCA, both P and C, and RA factor. You have this kind of neuroretinitis. It's a very classical book picture. Anything can cause a neuroretinitis. So I would advise a whole list of tests for this kind of clinical presentation, but it's not very common. So don't think that, if I've written all these tests at the bottom, you would apply for any case of uveitis. No. Coming to the lab testing guidelines, you may ask when to do CBC. It's not required for uveitis per se, but for general health of the patient, where you want to start some drugs which may affect, which are hematologically toxic, or you want to look for side effects, you do LFT, RFT, but this depends upon case to case. The metabolic profile, again, because many of these patients are being started on systemic steroids, please at least get a baseline sugar done. Even if the patient says I'm non-diabetic, get an RBS done. Many times you detect the patient unknowingly. So get a baseline RBS, get BP checked, because you're going to put these patients on systemic steroids. Quantiferon TB Gold, I don't recommend ordering this at first go if you see any granulomatous uveitis, whether it's anterior or posterior, because we have a much easily available, much simpler, much cheaper test, Montux test. In case you don't, the patient misses the reading of the Montux, which is typically at 72 hours, or the previous Montux is, kind of indeterminate, or you're strongly still suspecting TB, but the Montux is negative, then we would order an IGRA test. It is costly, so think about it before you order this test. Syphilis, remember, if you noticed, I mentioned TPHA in my slides and not VDRL, because TPHA is for detecting syphilis. VDRL, if the patient has been treated, it becomes negative, but TPHA is like once positive, forever positive. So if the patient has had syphilis anytime, it will remain positive forever. Once you have a TPHA positive, go for VDRL, because that is where you're going to start your antisyphilitic treatment and monitor the patient on VDRL titrers. So if you say, first instance, you're seeing a patient of uveitis, VDRL negative, no, do a TPHA. Serology, we don't really resort to, although there are some people who do serology testing for syphilis. Sarcoidosis, I'm sure you see these prescriptions of serum ACE and lysozyme. They have a very poor positive predictive value. It's just that you want to corroborate your testing, but they are not really recommended for diagnosing sarcoidosis. They have very low positive and negative predictive values. HLA-B51 classically mentioned for Behçet's, but it is positive in 18% of normal population. So again, if you have positive, it does not really mean it's Behçet's. If it is negative, it does not really mean it is not Behçet's. So you have to clinically correlate. If you have hypopion uveitis with Fern pattern vasculitis with a positive HLA-B51, I would give marks credit to this test. Otherwise, I will not. Serology for viral and toxo, IgG, IgM, it just differentiates between a recent and a past infection. But again, if negative, it does not rule out. So please pay attention to your clinical clues. Good uveitis workup in clinical practice means pay attention to the history, clinical examination, and just the basic ancillary tests. As I said, some of the tests are required when you see a granulomatous uveitis, and systemic disease is not always there. It's a very low, you must have seen most of the uveitis patients do not have any underlying systemic disease, but that does not mean that you do not do the systemic examination, because they don't tell, they're not aware of it. So if you pick up, your examination picks up a systemic clue, you give a lot of credit to yourself that yes, I picked up the patient with a systemic sarcoidosis. So you don't have to order these tests routinely in every patient. It has to be based upon the clinical presentation. And of course, if you're not able to, because you're going to go to private practice and here and there, so just refer. You don't have to keep on harping. If you don't understand, just refer to your colleagues or to higher sectors. Thank you very much.